Good morning. My name's James Stage on a nice sunny Australian winter's morning. This video, I'd like to talk about a recent publication addressing the issue of adenomyosis and IVF. This paper published in Reproductive Biomedicine Online in August 2026. That's being published next month. By a set of Italian authors, the effect of adenomyosis on cumulative live birth rates in oocyte donation cycles, a retrospective analysis. So by way of background, what is adenomyosis? And once again, I have to say right from the outset, this is really a clinical matter, a gynecological matter, and I am a mere embryologist, so I'm really speaking out of my depth in terms of the clinical application of it. My interest in it is for, as a client, being able to the diagnosis, the reporting, and the impact of IVF on success rates of adenomyosis. So you'll excuse me if some of the information is somewhat non-clinical. So adenomyosis is a non-cancerous condition with a tissue that normally lines the uterus, the endometrium here, grows into the muscular outer walls of the uterus, the myometrium. This displaced tissue thickens and bleeds with menstruation, which causes the uterus to enlarge and results in symptoms like severe cramping and heavy periods. So there was a slight question about what's the difference between adenomyosis and endometriosis, and the answer is, while both conditions involve endometrial tissue growing where it does not belong, they are distinctly different. Adenomyosis occurs strictly within the muscular walls of the uterus, whereas endometriosis occurs when this tissue grows outside of the uterus, such as on the ovary, fallopian tubes, or bowels. Although they are very different, they frequently overlap and can occur at the same time and can be misdiagnosed. So, I think I got a bit carried away in the preamble here. Adenomyosis is a condition that affects your uterus, your womb. It happens when the cells that normally line the inside of your uterus also grow in the muscular layer. And it's thought that about 1 in 5 females have an adenomyosis. It usually affects females who have periods aged between 30 and 50. And I've included this because the identification, the prevalence of it does seem to vary amongst who you're looking at. And once again, that's pronounced adenomyosis, is where the tissue lining the uterus starts to grow in the muscular wall. It can cause painful periods, heavy and prolonged menstrual bleeding with clotting and abdominal pelvic pain, and my sympathy goes out for any person with this condition. But the issue really for this paper is the identification of it and the impact of different sorts of adenomyosis on clinical outcomes. Now, I've been around ultrasound for the last 50 years, and I have no skills at all in identifying the adenomyosis in this ultrasound of the uterus. This is a transverse section running this way from the fundus to the cervix, and this is the outer layer, the myometrium layer, and this is the endometrial, the inner layer, and the endometrium, and the cavity here, which is as described as the fairly largest V-shaped cavity, is actually very, very thin and lines the inside of the endometrium. I'm going to come back to this because I think the essence of this paper is that the diagnosis of adenomyosis has clinical implications, and I suspect the skills in ultrasonography and identifying adenomyosis is the issue at hand. So let's just start with the question that the authors posed. So what is the effect of adenomyosis on a cumulative live birth rate in women undergoing a single embryo transfer in donor oocyte cycles with specific attention to type, location, and the severity of the disease? And why this paper is important is they're using donor oocytes. And so many women with endometriosis, adenomyosis will be in their middle to late 30s, early 40s. And therefore, when you try to use eggs from these ladies, they have a lower birth rate, inherent birth rate. So by looking at donor oocytes, only cycles where the donors are usually under 30, it removes any impact of ovarian reserve on the outcome. So we're only actually looking at the impact on the recipient's endometriosis. And they found the ultrasound mapping to identify adenomyosis location is crucial in fertility counselling. Adenomyosis involve the outer myometrium and junctional zone presented a lower cumulative live birth rate, and no difference were found in serum progesterone concentrations. So the arguments here is they're suggesting whereabouts the endometriosis and severity is located will change the outcome, and you need to know that information when you're being counselled by your clinician. So the cumulative live birth rate is where you create lots of eggs, make lots of embryos, and then you put them all back one at a time to try and reduce the incidence of multiple pregnancy. But what is your chance of having a baby when all those embryos have been put back? So initially, a lot of people just looked at the first embryo transfer, but in reality, most clinics now are looking at the cumulative live birth rate as the ultimate diagnostic tool, whether a procedure has impact or not. And in this case, the authors found that there was no difference in the clinical live birth rate between those women with adenomyosis and those that did not. So that's kind of good news. However, they then went back and said that women with adenomyosis in the outer myometrium and the junctional zone, this is, I assume, the outer myometrium and the junctional zone, had a lower cumulative live birth rate, 62%, compared to those with adenomyosis. Sorry, let me go back and repeat that. Women with adenomyosis in the outer myometrium and the junctional zone had a lower cumulative live birth rate, 62%, compared with those with adenomyosis limited to the junctional zone or the myometrium. So in other words, if you have a bit of adenomyosis in any one place, it doesn't seem to make a lot of difference. But when you have it in more than one place, it seems to affect it. But the cumulative live, this is actually exceptionally high birth rates for donor eggs. This is about as good as it gets. But you can see that it's just a reduction of 82%, 82% to 62% really is not a great deal in the grand scheme of things, or some people I think may do. But it needs to be done when it's being in terms of counselling. The estimated number of transfers for 50% cumulative live birth rate was also higher in the outer myometrium and junctional zone group versus the junctional zone or myometrium alone. Okay. Not a lot of people are using this estimated number of transfers, 50% live birth rate, something stat I haven't seen before, and may well find that being used more frequently. Multivariate analysis confirmed the outer myometrium and junctional zone adenomyosis as a negative predictor of live birth, right? But there's no significant difference were found in live birth by type of severity of adenomyosis or serum progesterone concentration. So even though there was a difference between whereabouts the adenomyosis is being identified, the severity, etc., doesn't seem to be an indicator. So I just want to go back and look at a couple of other papers that might provide a bit more information for you. This is actually a paper published in 2024 looking at the live birth rates against the morphological uterus sonographic assessment groups, where they're specifically looking at it. So this is focusing a little bit more on the ultrasound diagnosis of it. The presence of a direct or indirect MUSA, which features endometriosis, correlates to reduced live birth rates in women undergoing their first IVF treatment. So these are people who are not using donor eggs, they're using their own eggs. And in this case, these authors suggest there was a difference. Features located in the inner myometrium, in particular the interrupted junctional zone, reduced the chance of live birth most, whereas the location in the outer myometrium versus associated with a higher chance of live birth. So once again, it's the location of the endometrium and adenomyosis that's important. Systematic ultrasound examination should be considered for women scheduled for IVF ICSI treatment for adequate counselling on the chance of successful treatment. And basically, for their data, they suggested that the cumulative live birth rate after the first cycle of treatment, that is on all ages, but on their first cycle, was 40% in the total cohort. Women with direct features of adenomyosis had a lower cumulative live birth rate, down to 24%. So this is a bit different to the data for women using donor eggs. So it may well be that the endometriosis adenomyosis is having some impact, or maybe just being identified in older women. The adjusted relative risk for a live birth for women with direct feature of adenomyosis compared to women without was 62%, then was significant. Therefore, Yeah, that is, in other words, if you had adenomyosis, the relative risk of you not being pregnant is significantly high. That's a higher chance of not being pregnant, or pregnancy rate's lower. But coming back to the study, which is the focus on this video, the adenomyosis was confirmed with the presence of at least one direct feature visualized by 2 or 3-dimensional transvaginal ultrasound classified according to type, diffuse or focal, localized inner or outer myometrium and or the junctional zone, and the uterine extension mild, moderate or severe. After an artificial or natural endometrial preparation cycle, patients underwent a standard single embryo transfer, and the main outcome was the implantation rate. And once again, I've already gone through the data, but what I'm only reiterating here, this study demonstrated that although adenomyosis did not significantly reduce the odds of implantation, the direct signs of adenomyosis in the junctional zone and the disease severity in patients receiving donor oocytes was important. This study highlights the importance of thorough ultrasound examination and detailed adenomyosis classification in the assessment and management of patients with infertility. And I think this is the key point from the article, which I like to translate to viewers who have adenomyosis. How it's being diagnosed is the critical thing. So let's just return back to these images. Once again, trying to identify the myometrium should be straightforward for an ultrasonographer, maybe not for a nurse. A lot of IVF now is being done by nursing, just looking at follicles, size, etc. But that's not what we're talking about here. We're talking about having an assessment done prior to your first fertility treatment, such that the clinician can then give you fertility advice on your chance of pregnancy. So just we've been talking about the outer and middle and inner myometrium, the endometrium. This is, once again, this is what you see on ultrasound. I think it's probably or some pictures could be better. And this is what we're actually meant to be looking at. So here you have an outer muscular myometrium, which is highly vascularized. There's a layer of musculature inside that vasculature. And then there's a junctional zone between that and an inner myometrium, which is the layer of muscles just out on the next to the endometrium itself and the endometrial lumen. This is where the embryos go here. So you can see here where if the adenomyosis, I'm getting myself confused, is found here, or the junction or outer zone, it makes all difference in your likelihood of success. And when I saw this image, I thought, it's too hard. You do actually need to be an ultrasonographer, and I don't know whether there are EQA programs for the identification of adenomyosis. I like to do with my FERDATE EQA program. If any doctor's listening that wants to set up an EQA program for testing of staff and how they can identify it, please contact me. But you can see it's actually very, very complicated. You can do it diagrammatically, whether it's diffuse or focal adenomyosis, etc. But seeing an ultrasound, I think, is quite difficult. And I think you do need to have a specialist ultrasonographer and a really good machine. So I thought I'd just sort of finish up with a bit of background stuff and then finish right at the very about the clinical risks. I think this was an education thing for me, so I hope this for you as well. Adenomyosis was first described in 1860 by an Austrian pathologist who stated that the endometrial stroma and glands were unexpectedly present in the myometrium. In the last century, adenomyosis was defined by the infiltration of the endometrial bacillus layer, glands and stroma, into the myometrium through an altered junctional zone. So it really is if the junctional zone is the problem, a highly specialized hormone-responsive layer of the uterine architecture located in the inner third of the myometrium. Endometrial migration is accompanied by myometrial hypertrophy, hyperplasia, and fibrosis. So really, in a funny sort of way, it's the breakdown of the functional integrity of this junctional zone, which is half of the problem. In the past, it was thought that adenomyosis almost exclusively affected women in their 40s and 50s, and therefore to a large extent outside the range being treated by IVF. Whereas adenomyosis is currently increasingly identified in young women with pain, abnormal uterine bleeding, and infertility. Thus, adenomyosis has turned into a heterogeneous clinical condition rather than a histopathological finding. Despite new diagnostic tools, adenomyosis often remains a missed disease, poorly known in both primary and secondary care. It is often overlooked or misdiagnosed as common gynecological comorbidities, such as uterine fibroids and endometriosis. The enormous heterogeneity in clinical presentation and imaging findings and the low awareness of this condition amongst clinicians makes it challenging to diagnose. Furthermore, the management of adenomyosis does not follow shared recommendations given the lack of approved drugs and tailored treatment approaches, even though adenomyosis requires a lifelong management plan, including symptom control, fertility, and pregnancy complication. And I don't wish to be on, this is really a clinical matter, but in this article, which was 2025, so that's only last year, there is a management plan that maybe all fertility clinicians should be aware of, and indeed women who have adenomyosis should be aware of the clinical options available to you. So don't be afraid to ask your doctor if you have a woman's been diagnosed, if you have, actually I'm getting into a clinical area here, but if you have abnormal menstruation, bleeding, etc., you need to ask your doctor if this is a condition of adenomyosis. And there is a strategy there about if there's no symptoms, you do standard IVF, and if you have recurrent failure, then you go on to a process using generation 8 to pre-treat and maybe reduce the endometrial activity for 3 to 6 months before you do a transfer. There's also issues surgery and freeze-thaw, which I don't think is the remit for this video and my skill set. For individuals with persistent or recurrent symptoms, conservative surgery may be considered to enhance reproductive outcomes, especially in cases of focal adenomyosis, and we've already discussed what that means. In patients who are asymptomatic or have mild symptoms, standard ART cycles are recommended. However, in cases of implantation failure or recurrent miscarriage, a freeze-thaw strategy with pre-treatment using gonadotropin-releasing hormone for 3 to 6 months before transfer is proposed to optimize endometrial receptivity and improve pregnancy outcomes. Furthermore, if the ART freeze-all strategy fails, conservative surgery may be considered, but once again, this is a gynecological matter and outside my scope. But the authors do make the point that adenomyosis poses substantial challenges to women's reproductive health. Despite the improvement of non-invasive diagnostics I've said everything, I think I'm repeating myself here, the awareness of the condition is still poor and diagnosis is often missed due to the heterogeneity of clinical presentations and imaging criteria. Furthermore, the lack of approved drugs represents a considerable challenge in this clinical management. In addition, medical and surgical managers do not follow shared recommendations, even though adenomyosis requires a lifelong management plan, including pain and bleeding control, fertility preservation, and pregnancy complications. Thus, efforts are needed to raise awareness amongst healthcare professionals, aiming for early diagnostic conditions for timely management and a tailored treatment strategy. And just want to finish up, there's another paper I came across in 2022, increased risk of obstetric complication in patients with adenomyosis. So this is another area, a lot of people getting interested in the obstetric management of people, particularly of people on HRT. So this paper says something like, reproductive age women occasionally face the pathological conditions of adenomyosis, which is often concurrent with endometriosis, they often get mixed up. It is believed that endometriosis and adenomyosis increase the risk of obstetric complications. Although new insights into the mechanism of obstetric complications due to endometriosis are emerging, there is little information on the etiology of adverse pregnancy outcomes in pregnant women with adenomyosis. However, they do say the main findings of this study, the prevalence of adverse pregnancy outcomes, is so wordy. The prevalence of adverse pregnancy outcomes in women with adenomyosis is increased after adjusting for conceiving by ART. Thus, adenomyosis emerges as a relevant factor associated with several obstetric complications such as preterm birth, preterm premature rupture of membranes, placental abruption, small for gestational age, fetal growth restrictions, and pre-eclampsia. So if you have adenomyosis, not only may be the slight problem getting pregnant, although it doesn't really appear that your pregnancy rate is significantly diminished in most cases of endometriosis, just Depends on the location of it. There is an increased risk that you'll have some form of pregnancy complication that your doctor does need to be aware of. So just coming back to the original paper, the conclusion was, I think there's a fair amount of repetition in this video, I apologize for it. Ultrasound mapping to identify adenomyosis location is crucial in fertility counselling. Adenomyosis involved the outer myometrium and the junctional zone presented a lower cumulative birth rate. So that is a take-home message. So my comments, being non-gynecologist, etc., just a mere embryologist, overall, adenomyosis does not appear to be a significant reason for unsuccessful IVF. It does appear to reduce in a small way, that leading to a lower live birth rate and a slight increase in the likelihood of miscarriages. It does seem that diagnosis by ultrasound requires the examination by a skilled ultrasonographer who knows how to identify and classify adenomyosis, and not by less skilled nursing staff. It seems that pregnancy is affected when the adenomyosis affects both the inner and outer myometrium, and may be a case of repeated miscarriages. The transfer of euploid embryos to address repeated miscarriages would benefit from a specific ultrasound examination, and if adenomyosis is identified, then there are treatment options that may be beneficial. So just finishing up, adenomyosis may be a hidden disease, and I haven't really come across it. Of all the 50 years I've been involved in IVF, adenomyosis was not even on the high to middle list of clinical conditions. And I do agree, I think it's probably been underdiagnosed. Adenomyosis may be a hidden disease, but easily identified if looked for, and may, in affected cases, with specific management, deliver an excellent cumulative live birth rate. So that's the finish. That's my lot for the week. My name's James Danger, and I'm an embryologist with more than 50 years experience. These videos are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice. If you like what I'm doing, press subscribe and like, and please leave a comment. These videos are being funded by my other online program, Third EQAP Online, which is an online EQA and training program in andrology, embryology, and ultrasound. I do one follicle and the endometrial thickness. But if you are a clinician and interested in quality, I'm quite happy to discuss the option of having an additional EQA program looking at the identification of adenomyosis. And that, my lot, is your friend for the week. I'd like to thank you for your time, and I hope this information may be of value.